Hey guys, want to do a quick post on ptosis. I think the biggest questions I get from you guys are, how do I fix this ptosis? How do I do this? How do I do that? So the most important thing you need to do is first, always take a before picture of your patient just like this. Right here, you can see this eyebrow's lower, this one's higher. Ptosis wise, you see how this lid is lower, that one's higher. You have to show your patient, especially when the patient's eyes stick out more, you have to show them their resting ptosis. Be like, hey, see, you see here, that's my resting ptosis. That means technically your levator could be different on that side. Your muscle and the Botox can slip in there and make that ptosis a little bit worse. Sometimes people, if it really bothers them, you have to tell them like Botox might make that worse initially before it gets better. It's just very good to show them their asymmetries beforehand, because our practice manager I'm about to show you next, she had a ptosis, but it was caused by kind of, I think, all therapy, not by the Botox, but her resting ptosis was more. Sorry, it got cut off, but I like to show this. You see the levator muscle, you see the frontalis muscle, you see the orbicularis oculi muscle. So if someone has a very hooded frontalis muscle, meaning their eyebrows are very low set, it can make them feel like they have ptosis, but they might not. It just might be they're very hooded. But you can see on the patient I'm about to show you that she actually has very outset eyes. So when that happens, her eyes come out. So her lid is very long. That tells me her levator is probably long. That means I need to explain to her that lid ptosis that she naturally has might get worse, but the way in my head I think about it, it's a red flag. I really think, oh my goodness, this person has a very long lid. I need to be very careful. I'll not overdo the Botox, and I need to make sure I'm in that corrugator and not the frontalis. And when I do orbicularis oculi, I really want to make sure I'm very lateral. You can see your temporal fusion line is a little bit more medial, so I really want to make sure that I stay very lateral. And the biggest lesson to learn is everybody is different. And if you have a lid ptosis, maybe it's not your fault, but you need to know how to treat it. So I'm going to show you guys right now. Happen to patients. You can see this eye, she has resting ptosis in her left eye. An oculoplastic surgeon can actually measure what it is. I would say it's like a 1 to 2 millimeter ptosis. That's resting, right? And she had Botox done 2 weeks ago. And look at the camera, and then you can see this ptosis has worsened. So we have to look at her before photos to see if this had more of a ptosis prior, because some patients do. One eye will be more ptosis naturally, and then one is higher. So you have to show your patient like, hey, see this one? This one's already naturally ptosis. So this has been 2 weeks since the actual Botox, and then open your eyes as wide as you can. And the assessment that you do is you have them open as wide as you can. What can she do when she opens wide? She overcompensates with her levator here, and then that tells me that that muscle is still intact. So open as wide as you can. It's still intact, but you can see the ptosis is a little bit more prominent on this side. And then you have them do a full assessment of their muscles to see what muscle was impacted. Raise up your eyebrows as high as you can. Frontalis is frozen, so that tells me it could be partial frontalis along with levator. And then you have them, I'm gonna just put my finger here, close your eyes hard as you can, close as hard as you can, squint like there's sun in the, and she's completely toast. Frown as hard as you can. So corrugators are completely frozen. Frown as hard as you can, and then scrunch up your nose like a bunny. She's completely you're just frozen. Smile as big as you can. Good. And then what part of her orbicularis oculi is still intact, the inferior aspect of it? And what did you notice was going on under your eye?
So twitching. Like under this eye.
Yeah, and that can happen as your Botox is wearing off, or if a certain aspect, remember this is a gauged muscle, so it's a sphincter muscle. So if this is toast, or this is too heavily impacted, then this aspect here will start to twitch more. So then we have to do 2 spots. Above the eyelid, right on the eyelid, right by the levator, and then an inferior aspect of orbicularis oculi. So close your eyes as tight as you can, close, and then open, and then smile as big as you can, super big. So we need to add more, and this, she's Middle Eastern, so I call it the cusp. Right here, right here, right here, and then right on the eyelid. All right, so the toxin we're gonna use is Dysport. Smile as big as you can. Good. And then open your eye. Close your eyes. And then 1, 2, 3, open. Open as wide as you can. There you go. Good.
Okay. Relax. Okay, and just stay still. Close your eyes.
So Hania is going right above the lid line, 1 to 1 with Dysport. She's just popping the needle right under the skin. It's very thin. Then she's gonna create a wheal. And it's a very, very, very small little injection. And you can see basically she's just doing 1 unit. So this is something you're gonna underdose and then have the person come back, smile, and then she's going right into that little wrinkle, popping under. And here you can be more generous. You can do 1 to 3 units. Just on the lid, you're gonna do very, very, very minimal. And I call this the little crease. See that little crease there? So you can see when she smiles, it comes up. And so I have to do inferior and superior. And then every day we'll take a video and a little picture here. Relax.